My name is Mamata Bhatt, and I'm a transplant hepatologist and clinician scientist at the University Health Network in Toronto, Canada. I'm here to speak to you about an upcoming publication in Mayo Clinic Proceedings in September 2018 entitled Immunosuppression, Race, and Donor-Related Risk Factors Affect De Novo Cancer Incidence Across Solid Organ Transplant Recipients. This is a publication that I've written in collaboration with Dr. Kimberly Watt, Medical Director of Liver Transplantation at Mayo Clinic in Rochester, Minnesota. In this study, we evaluated the large experience from the Scientific Registry of Transplant Recipients in the U.S. in order to investigate de novo cancer incidence, as well as to explore and evaluate the risk factors that are predictive of this de novo cancer incidence across solid organ transplant recipients. We looked at immunosuppression regimens, demographic and clinical characteristics of recipients, as well as donor-related features in order to determine whether these predicted cancer incidence post-transplant. Certainly, de novo cancer incidence is known to affect morbidity and mortality post-transplant, and this is why it is important to better understand what are predictors of de novo cancer in order to learn how we can modify our practice accordingly in order to minimize post-transplant cancer risk. In our study, we discovered that the overall 15-year cancer incidence ranged from 13% in kidney transplant recipients up to 28% in heart transplant recipients. We also determined that the most significant predictors of de novo cancer incidence included the use of 2 or more immunosuppressants, white race, older age, male sex, as well as donor age and donor white race. Conversely, the use of mTOR inhibitors such as sirolimus as immunosuppression decreased the risk of de novo cancer post-transplant, especially in the context of skin cancers. Therefore, in summary, transplant recipients are certainly at a higher risk of malignancies as compared to the general population, especially those patients who are recipients of heart and lung transplants. Increasing donor age and white race represent predictors of heightened cancer risk across all solid organ transplant patients, and the presence of multiple immunosuppressants with different mechanisms of action increases the malignancy risk, as witnessed in the higher risk among heart and lung transplant recipients as opposed to kidney and liver transplant recipients. Overall, our study findings suggest that we should tailor our immunosuppression in order to limit the exposure to immunosuppression in the long-term post-transplant. Whenever possible, one should minimize the number of immunosuppressants as well as the degree of immunosuppression used in order to prevent cancer incidence, especially in those patients who are older, white, and male with a history of malignancy. More careful screening for malignancies of transplant patients with these risk factors should be considered in order to optimize their post-transplant survival. Thank you very much for your attention, and I hope that you will enjoy our publication in the upcoming issue of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.